Hello, this is John Green. I'm one of the pediatric anesthesiologists at University of Kentucky. This is the Anesthesia ITE Keyword Review for 2022. This is the second part of a pediatric review, and this focuses on pediatric pathologies. Our first keyword is pyloric stenosis. Pyloric stenosis is hypertrophy of the pylorus muscle of the stomach, and this causes obstruction to gastric emptying. The prototypical patient is a male, often 2 to 6 weeks old, presenting with non-bilious projectile vomiting, especially after eating. The other prototypical presentation includes a palpable olive-shaped mass noted in the epigastrum. These patients will have a hypochloremic metabolic alkalosis. Again, very important, hypochloremic metabolic alkalosis. They can also be hypokalemic and or hyponatremic, and they will almost certainly be dehydrated. It is important to understand that this is not a surgical emergency. The patient should be optimized with medical management prior to coming for surgery, utilizing normal saline IV fluid with the addition of potassium and dextrose once they begin urinating. Signs of adequate optimization include a relatively normal heart rate and systolic blood pressure, a pH between 7.3 and 7.5, potassium greater than 3, chloride greater than 90, sodium greater than 130, a bicarb less than 30, and most importantly, a urinary output at least 1 ml per kil per hour. Treatment is with pyloromyotomy, typically a laparoscopic approach. Some of the anesthetic considerations for these patients, they are very, very prone to aspiration. So these patients should be suctioned orogastrically with passing an OG tube at least 3 times in the supine, left lateral, and right lateral position. Some people will actually suction in the prone position as well. The goal is to empty as much of the stomach as possible. They should be pre-oxygenated for at least 3 to 5 minutes because they're going to desaturate very quickly. And then they should be intubated either awake or with an RSI technique. It's important to know that these patients are very prone to postoperative apnea. So opioids, if utilized at all, should be minimal. And typically we do not utilize any opioids for these patients. Usually pain can be very well controlled with local anesthetic infiltration by the surgeon at the laparoscopic sites, and typically rectal Tylenol is all that's needed. These should also be extubated awake. Our next keyword is hemoglobinopathies, and sickle cell disease is one of the other keywords, so I kind of combined these. As a review, hemoglobin S is the mutation in sickle cell disease, which substitutes valine for glutamine on the beta globin chain. And in a hypoxic environment, this causes the hemoglobin S to aggregate and polymerize, which leads to red blood cell deformation and precipitation. And this causes hemolysis, microvascular occlusion, and end-organ ischemia. Remember that these sickle cell patients have different types of crises. They can have vaso-occlusive crises, which lead to microinfarcts. They can have aplastic crises, which cause bone marrow suppression. A lot of these patients have splenic sequestration and functional asplenia, which predisposes them to risk for infection. They can have hemolytic crises, especially if they're G6PD deficient. And they can also have acute chest crises, which result in respiratory failure and or pneumonia. So preoperatively, they should be assessed for their crises history. They should be assessed for signs and symptoms of infection, volume status, and any evidence of end-organ ischemia, such as strokes, avascular necrosis, lung infarcts, MIs, etc. Anesthetic considerations for these patients. Typically, sickle cell patients are transfused to a hemoglobin greater than 10 prior to any moderate or high-risk surgery. It's important to understand that the previous suggestion to transfuse, to exchange transfusion to a goal of hemoglobin S less than 30% has not been shown to be of significant benefit. So typically these patients do not undergo an exchange transfusion, but they are transfused packed red blood cells to a hemoglobin at least 10 for moderate and high-risk surgery. The other anesthetic considerations for sickle cell patients are to avoid the stressors that can cause crises. So you want to avoid hypo or hyperthermia. You want to avoid hypovolemia or hypotension. Avoid hypoxia, acidosis or hypercarbia, infection, venous stasis such as tourniquets. So you should avoid tourniquet use if at all possible, and then also avoid anemia. Our next keyword is congenital diaphragmatic hernia. This is a defect in the diaphragm leading to the extrusion of abdominal organs into the thoracic cavity. Most commonly is Bactelic's hernia, which is the left posterolateral, so that is the most common site for this herniation. Clinical manifestations include pulmonary hypoplasia, as well as pulmonary hypertension. You can also see respiratory distress, scaphoid abdomen, and bowel sounds in the left chest. Surgical intervention should be delayed until these patients are medically stable. It's important to realize that there is a strong association with other congenital anomalies with congenital diaphragmatic hernia, so these patients should be evaluated prior to surgery. Echo, usually a spinal ultrasound looking for cardiac, vertebral anomalies, things like that. Anesthetic considerations. Typically, it is a gentle ventilation strategy with these patients because we want to avoid damage to the ipsilateral hypoplastic lung as well as damaging the contralateral lung or providing a pneumothorax. Gentle ventilation strategy includes low tidal volumes with permissive hypercapnia, a reduction in peak inspiratory pressures, ideally less than 25. FiO2 and PEEP are titrated for a goal preductal sat of 90 to 95%. And a lot of these patients will be on jet ventilation or high frequency oscillation ventilation. Additional considerations include prevent any worsening of the pulmonary hypertension, which will cause further shunting through the PDA and or the PFO, worsening hypoxia and metabolic acidosis. So essentially you want to avoid anything that would increase pulmonary vascular resistance. You should consider the use of inhaled nitric, Flolan, or milrinone. Maintain normothermia due to the negative consequences of hypothermia. And this is a separate keyword here. So with closure, you want to watch for any deterioration specifically to lung function with surgical closure. If there's any evidence that there's increased abdominal pressure, which would lead to impaired ventilation, then the surgeon may need to place a celastic silo and delay closure to another day. Our next keyword is emergence delirium. This is non-purposeful restlessness and inconsolability, usually seen upon waking up in PACU. Risk factors for emergence delirium is usually seen in the young, typically ages 2 to 9. Patients that have pre-op anxiety, and this also includes parental anxiety. Those are both risk factors for emergence delirium. A previous history of emergence delirium is a risk factor. The less soluble volatile anesthetics such as sevoflurane, which we use on most pediatric patients. Pain is another risk factor, and then there are certain surgeries that predispose to emergence delirium. A lot of the ENT surgeries, TNAs, as well as the eyeball surgeries. Treatment for emergence delirium, things that can help. Pain medications such as Toradol and fentanyl, especially when these are given intraoperatively. Precedex and or clonidine can help. Propofol can help treat it. The main thing to realize is that this will resolve spontaneously, whether we treat it or not. And so it's kind of important to talk with the parents, tell them that this is not an uncommon occurrence, because it's very disconcerting to the parents. Just let them know, reassure them that this will go away. We're going to try to treat it, but it will go away very soon, usually within 45 minutes. Honestly, it's usually 20 minutes. Our next keyword is Down syndrome. The majority of these Down syndrome patients are a result of trisomy 21. They have quite a few considerations. Some of the general considerations involve airway is prone to obstruction due to facial anatomy, large tongue, hypertrophic tonsils. They are prone to having subglottic stenosis, and many of them have obstructive sleep apnea. Almost 50% of Down syndrome patients have a coexisting congenital heart defect, such as endocardial cushion defect, VSD, ASD. They are at risk for pulmonary hypertension due to either congenital heart disease, chronic airway obstruction causing chronic hypoxia, or both of those processes. They're prone to generalized hypotonia and joint laxity, including being prone to atlantoaxial or occipital-atlantal joint and cervical spine instability. They may be moderate to severely mental or developmentally delayed. They have a relative immune deficiency, which predisposes them to risk for infection, and they also have an increased risk for leukemia. They often have coexisting hypothyroidism and or diabetes. They have below normal catecholamine levels and an altered autonomic cardiac regulation, which blunts their response to hemodynamic changes. And then another consideration is they are prone to GI problems, such as duodenal atresia, GERD, things like that. So anesthetic considerations: all Down syndrome patients should have an echo by 6 months old, with ongoing cardiology follow-up if any defect is found. And if so, be aware that SBE prophylaxis may be required, depending on what the surgery is and the underlying heart disease they may have. Ask about any upper respiratory infections due to airway concerns and their already impaired immunity. If there is any evidence of neurodeficits, consider C-spine imaging due to the potential for possible joint laxity and cervical spine instability. These patients are very prone to bradycardia, especially with inhalation induction. Some providers elect to go ahead and treat with IM atropine if they're planning an inhalation induction. They should have careful airway assessment, and remember to consider downsizing their ET tube due to their risk for having subglottic stenosis. Duchenne muscular dystrophy and Becker muscular dystrophy are our next keywords. These are X-linked recessive mutations which prevents normal formation of dystrophin. Becker differs from Duchenne in that it's only a partial loss of dystrophin rather than an absolute loss in Duchenne. This results in painless proximal muscle weakness and motor delay, which progresses to severe muscle atrophy. So some of the general considerations, first and foremost, these patients have a high incidence of cardiomyopathy and or cardiac arrhythmias because of the cardiac muscle involvement. So all of these patients should have a thorough cardiac workup, ECG and echo at the time of diagnosis, and continual follow-up. They also have a decreased ability to cough, which predisposes them to respiratory tract infections. They have potential for hypomobility of the GI tract, which can delay gastric emptying. And then something that we'll discuss here in a minute, female carriers are typically asymptomatic, but they may also still have the cardiomyopathy and or the rhabdomyolysis hyperkalemia with succinylcholine and volatile anesthetic exposure that we'll discuss in a minute. So anesthetic considerations, again, thorough cardiac workup. preoperatively. They're at risk for aspiration, they're at risk for post-op ventilation difficulties and a possible need for post-op mechanical ventilation. So these patients have an increased risk of rhabdomyolysis, hyperkalemia, and or cardiac arrest with exposure to succinylcholine and volatile anesthetics. So these agents should be avoided if at all possible. It's thought that the reason for this is due to a upregulation of nicotinic acetylcholine receptors in these patients. There is no proven increased risk of malignant hyperthermia in these patients. Very important. These patients have never been proven to have an increased risk of malignant hyperthermia. However, not a bad idea to make sure that dantrolene is available nearby just in case. And then also non-depolarizing neuromuscular blockers can be used if needed, but avoid them if at all possible. Our next keyword is epiglottitis. This is an acute onset of supraglottic edema, usually due to a bacterial infection such as H. influenza. It can rapidly lead to total airway obstruction. Clinical manifestations include the 3 Ds, which are drooling, dysphagia, and distress. The patient will also have minimal cough, sudden stridor, a high fever. Usually they're toxic appearing and may be tripoding. So anesthetic considerations, hemodynamically unstable patients should be intubated immediately. Stable patients should be transported to the OR for intubation with oxygen mask and pulse oximetry, maintaining spontaneous respirations in a position of comfort. Ideally, you do an inhalation induction with sevoflurane, avoid desflurane and nitrous. An IV can be placed after induction to allow for additional sedation, but important to maintain spontaneous respirations and avoid neuromuscular blockers. ENT should be at the bedside, ready to place a trach if needed, and the most experienced provider should do the intubation. It's suggested to use a cuffed ET tube 1 to 2 millimeters smaller than you normally would. And these patients, after you relieve the severe obstruction, they're prone to pulmonary edema, so consider CPAP and PEEP after securing the airway. And these patients will need broad spectrum antibiotics. The next keyword is laryngospasm, which is associated with insufficient depth of anesthesia, typically around stage 2. It usually occurs during induction and or emergence. Triggers are multiple and include blood and secretions in the oropharynx, mechanical stimulation such as laryngoscopy, LMA or OPA placement, suctioning, and also surgical stimulation. Sometimes all it takes is to look at these patients wrong and they go into laryngospasm. Risks include age less than 5, a recent upper respiratory infection, asthma or eczema history, and then also household secondhand smoke exposure. Treatment is typically a stepwise approach, but it's a rapid stepwise approach, and by that I mean you should rapidly progress to the next step if it's not working, especially in these small pediatric patients, because they can decompensate very quickly. So you start with 100% oxygen. You can use Larsen maneuver, which, as a refresher, is bilateral pressure on the styloid process posterior to the ramus of the mandible. You can go to continuous positive airway pressure. You can deepen the anesthetic, such as administer some more propofol. And if that doesn't work, you rapidly progress to succinylcholine. If you don't have an IV yet, you can give succinylcholine IM and then intubate as quickly as you can, if necessary. Our next keyword is upper respiratory infections. Current or recent upper respiratory infections, by recent we mean especially within the past 2 weeks, increases the risk for perioperative pulmonary complications. These complications include coughing, laryngospasm, bronchospasm, transient hypoxia, croup, and pneumonia. Apneic oxygenation is less effective in these patients, so they will desaturate far quicker than normal. ET tubes cause more stimulation to inflamed airways than an LMA does. So if you can get by without having to intubate, that's ideal. And infants are at greater risk than older children. So when a child comes in for surgery who has a current or recent upper respiratory infection, proceeding with surgery depends on many factors. If it's an active infection, especially if they are toxic appearing or have fevers, drooling, productive cough, etc., the case should be canceled. Otherwise, there needs to be a risk versus benefit discussion with the parents and the surgeon, but always err on the side of caution. Truly elective procedures should probably be canceled unless continuous or chronic mild symptoms, such as just a simple runny nose that's clear, they've got just chronic allergic rhinitis, things like that. You can also consider avoidance of general anesthesia and or airway manipulation. Post-tonsillectomy complications. So some of the complications that can occur, they often have coexisting sleep apnea. So there's always the possibility of pulmonary hypertension, cor pulmonale, increased sensitivity to opioids, postoperative obstruction, things like that. Postoperative nausea and vomiting is common with tonsillectomies, and this is a result of pain, swallowed blood, and poor oil intake. Pulmonary edema is another potential complication, and this is because you're removing this airway obstruction, and so you have a relatively increased negative inspiratory pressure, so they can actually have pulmonary edema from that. And I guess probably the most significant or feared complication of post-tonsillectomy is bleeding. It's important to understand that this is considered an emergency. Now, this usually occurs within the first 6 hours, but it can occur as late as 8 days after their surgery. The patient will likely be hypovolemic and dehydrated, so that's going to cause potential hemodynamic instability, difficult IV, things like that. And they can also be potentially agitated and uncooperative. These patients should be treated as a full stomach because it's assumed that they've swallowed a lot of this blood. They should also be treated as a difficult airway due to the bleeding and edema. So they should have 2 large bore IVs, preferably 2. You should have blood available. They should be volume resuscitated. You can consider some glycopyrrolate for secretions. They should be transported to the OR in the lateral Trendelenburg position to allow to minimize the chance of swallowing or aspirating the blood. You should have all of your difficult airway tools and multiple ET tubes ready. You should consider having an assistant, preferably another anesthesiologist. Intubation should occur with an RSI technique. And then after intubation, remember to do OG suctioning, and these patients should be extubated awake. Our next keywords are the differences between omphalocele and gastroschisis. So as a review, omphalocele is a herniation into the umbilical cord. This results of failure of the midgut to go back into the abdomen during development. It is protected by membranes, and omphalocele is commonly associated with other comorbidities, such as the trisomies, Beckwith-Wiedemann syndrome, cardiac defects such as VSD, and genitourinary defects. Now, gastroschisis is a herniation of the abdominal contents through the wall of the abdomen, usually to the right of the umbilicus. It is not protected, so you have exposed abdominal contents, so there's a higher risk of dehydration and infection. General concerns for both conditions, both are medical emergencies, both should be treated as full stomachs. They're both prone to severe dehydration, shock, acidosis, and hypoglycemia. They're at increased risk for impaired ventilation. They're at increased risk for infection, as well as exaggerated temperature loss. So anesthetic considerations: you should have a warm OR with a radiant warmer and warm IV fluids. It should be a general endotracheal technique. You can consider a caudal epidural cath if there are plans for early extubation, which we'll mention in a minute. The airway should be secured with an RSI technique. Avoid nitrous. Consider A-line, a central venous catheter, definitely a Foley. And again, as we mentioned with congenital diaphragmatic hernia, when you're trying to reintroduce abdominal contents into the abdomen, which has not had those contents, it can severely increase intra-abdominal pressure, which can cause impaired ventilation. So with surgical closure, you need to closely monitor the patient for an increase in central venous pressure, peak inspiratory pressures, especially greater than 35, and or an increased abdominal pressure greater than 20. All of these are signs that surgical closure should be staged, and they should come back another day to close the stomach or close the abdomen. Extubation should only occur if it's a very small defect. Basically, the vast majority of these patients will require post-op ventilation, so they should go back to the NICU intubated. Our next keyword is tracheoesophageal fistula. Remember that type C is the most common. Type C is the one with a proximal esophageal atresia and a distal tracheoesophageal fistula. General concerns for these patients: they're at increased risk for aspiration, dehydration, pulmonary disease, acidosis, and hypoglycemia. They are also prone to having additional associated anomalies. For example, you have the Bacterial syndrome, which stands for vertebral, anorectal, cardiac, tracheoesophageal, renal, and limb anomalies. Anesthetic considerations for these patients: their airway should be secured either awake intubation or maintaining spontaneous ventilation with induction. The idea is you want to avoid any positive pressure ventilation, which could cause gastric insufflation, which can further impair their respiratory status. And when intubating, remember that the tip of the ET tube needs to be between the fistula and the carina. So there's a couple of different ways you can do this. If you don't have a bronchoscope immediately available, you can intubate, try to intubate the right main stem, and then withdraw slowly until you just get bilateral lung sounds, or you can just use a bronchoscope to initially guide placement. Our next keyword is prematurity. As a reminder, prematurity is anything less than 37 weeks gestation. Some associated conditions include intraventricular hemorrhage, retinopathy of prematurity, respiratory distress syndrome, bronchopulmonary dysplasia, and apnea of prematurity, persistent pulmonary hypertension of the newborn, and persistent fetal circulation, necrotizing enterocolitis, and sepsis. Additional concerns with the premature patient: they have an impaired glucose regulation, so dextrose should be a part of their maintenance IV fluids intraoperatively. They have increased susceptibility to hypothermia, so you should make sure to keep them warm. And then they also have decreased renal function and immature hepatic function, so keep this in mind when administering any medications that rely on liver or kidneys for either metabolism and or clearance. Our next keyword is mitochondrial myopathies. This is a group of disorders. I have listed here some of the more common ones, which result in a defect in the phosphorylation pathway. It disrupts energy metabolism and ultimately decreases the ability to use oxygen and generate ATP effectively. Clinical manifestations are varied, but they often present with CNS, musculoskeletal, and cardiac disruption. They're also prone to lactic acidosis. General considerations are to maintain metabolic stability and energy production, and to decrease perioperative stressors that could increase energy demands. So some of the anesthetic considerations are to minimize fasting times. These cases should be the first one of the day, or they should be admitted overnight for IV hydration prior to coming for surgery. You want to avoid hypothermia, anemia, hypotension, and inadequate pain control. IV fluids should contain dextrose and should not contain lactate, so no lactated ringers. You want to avoid high-dose propofol or prolonged infusion. However, it is generally considered that propofol for induction is okay as long as it's not high-dose propofol and you're not utilizing a propofol infusion. You want to avoid succinylcholine due to a risk for hyperkalemia. Again, this is not associated with malignant hyperthermia. This is due to the uptake in nicotinic acetylcholine receptors. And then careful titration of any non-depolaring neuromuscular blocking agents and sedatives due to their risk for respiratory complications. Pediatric airway is our next keyword. Some of the anatomical differences compared to adults. Neonates and infants have a relatively larger tongue. They have a more cephalid larynx at C3 to C4 compared to C4 to C5 in the adult. The epiglottis is short, omega-shaped, and angled away from the axis of the trachea. The anterior vocal cords are attached more caudal relative to the posterior vocal cords. So when you're doing laryngoscopy, the anterior vocal cords are actually sloped away from you. And then they also have a narrow subglottic region, whereas in adults, the narrowest portion of the airway is considered to be at the glottis. Another keyword is stridor. So as a reminder, inspiratory stridor is usually indicative of supraglottic or glottis obstruction. Biphasic stridor is usually a subglottic obstruction, and expiratory stridor is usually a distal trachea or mainstem bronchi obstruction. Causes are multiple but include laryngomalacia, subglottic stenosis, vocal cord paresis, and laryngopapilloma. So our last keyword is difficult pediatric airway syndromes and conditions. Now, these last two slides include a list of some of these syndromes, and it is certainly not all-encompassing, but I did try to put some of the ones that should just kind of catch your attention when you either see or hear about these syndromes, and be aware that they are associated with potential difficult airway, either in the form of difficult mask ventilation and or difficult laryngoscopy. So we have achondroplasia, specifically due to the craniofacial abnormalities and macroglossia that you may see. We have a pair syndrome, which is associated with some facial abnormalities, as well as a potential for cervical spine fusion. Beckwith-Wiedemann syndrome, primarily due to the macroglossia and midface hypoplasia. Cruzan syndrome, which is similar to a pair, also associated with cervical spine fusion. Down syndrome, due to the things that we've already discussed with Down syndrome. Goldenhar syndrome, which is associated with difficult airway, mainly due to the facial asymmetry. Pierre-Robin's sequence, which is primarily associated with oropharyngeal abnormalities. And then Treacher-Collins syndrome, which is associated with both facial and oropharyngeal abnormalities. So that concludes this presentation. Here are some of the references that I used, and I hope this has been beneficial. Thank you.